Clinically, what we see is almost 20% patients are seronegative. So once we call them seronegative, that means our traditional marker, which is rheumatoid factor and anti-CCP, as Dr. Ajay has just told us, are not useful. So now what are we left with for these 20% patients? So we are left with clinical judgment.
The landscape, when we talk about lab perspective, it came from rheumatoid factor to anti-CCP, and now we have a new novel biomarker, which is anti-MCV, or the mutated citrullinated environment team. It holds a very high promise that it is considered to be an early biomarker for the detection of rheumatoid arthritis, and not only in terms of early detection, but it has a role to play in the treatment part and then even in the prognostic part of the rheumatoid arthritis.
A lot of studies have shown that if treatment is taken at the right time, the structural damage is less in patients over the next few years.
To discuss this, we have with us Dr. Ranjan Gupta, Dr. Ajay Gupta, Dr. Shalu Bhasin, Gagneja.
New biomarker is catch hold of an early detection of rheumatoid arthritis. A separate panel with anti-CCP should be done because parallel testing of anti-CCP along with anti-MCV is mandatory now. Both of these markers complement each other. By testing both, we will be able to catch hold seronegative rheumatoid arthritis.
Anti-CCP, even though it is specific, you don't have the sensitivity. So basically one has a quality, both of them have one quality, but then there is a limitation behind all of them.
So we may miss some cases.
Yes,
That's what
exactly.
you want to say.
20%. At least 20%.
That's a huge number.
Anti-MCV, as per today's literature and studies, tells me that it can be positive in 40% of those 20%. So means my sensitivity of diagnosing seropositive rheumatoid arthritis shoots from 80 to 90. I'm able to catch hold of another 10% patients who were otherwise going to be labeled as seronegative.
Anti-MCV would bridge the gap of those 10 to 15% patients of seronegative rheumatoid arthritis. So we would be able to make an early diagnosis. Second thing is, because of the positive predictivity, its correlation of anti-MCV with the disease activity, morning stiffness, studies have shown that they are positively correlated. So probably in the future it would also help us in monitoring the disease. So I think that would be a game changer and it would help us in early treatment and diagnosis.
Welcome to our today's podcast, organized by Voice of Healthcare and supported by SIBIA with the theme Rheumatology and Broader Healthcare Advancements. This podcast will explore cutting-edge innovations in the diagnosis and treatment of autoimmune diseases. A highlight in the discussion will be Anti-MCV, a novel biomarker for seronegative rheumatoid arthritis, offering clinicians a powerful tool for earlier and easier diagnosis. This session will also reflect on how such advancements are shaping the future of patient care in rheumatology. To discuss this, we have with us Dr. Ranjan Gupta, Additional Professor, Department of Rheumatology, AIIMS, New Delhi. Welcome, sir. Dr. Ajay Gupta, Technical Director, Hematology and Immunology, National Reference Lab, Dr. Lal Patlab, Delhi. Welcome, sir. Dr. Shalu Bhasin, Gagneja, Director, Rheumatology, Primus Super Speciality Hospital and Consultant Rheumatology, Manipal Hospital, Gurgaon. Welcome.
Thank you.
So to begin with, my first question is to Dr. Ranjan. Rheumatoid arthritis affects millions worldwide. In your experience, what is the current prevalence of rheumatoid arthritis in India and globally?
So rheumatoid arthritis is the commonest inflammatory arthritis. And if we look at the prevalence, when I say commonest, the prevalence is usually 0.8 to 1% worldwide. And in India also it is not very different. So we see almost 1% of population which is affected by rheumatoid arthritis. There are different varieties of it that probably you will be discussing during the further discussion, but then that is the global as well as Indian prevalence.
And since it's so prevalent, we have to take care that how it is diagnosed and how it is treated. Dr. Shalu, why is early diagnosis of rheumatoid arthritis so critical for patient outcomes? What impact could earlier detection have on patients' quality of life and prevention of long-term disability?
Thank you for the invite. And so rheumatoid arthritis, as Dr. Ranjan said, is so common and it's increasing day by day. So the early diagnosis and treatment is really important because we all know that early treatment and timely treatment, I would like to say, will lead to prevention of irreversible joint damage and a improved quality of life, and the functional ability of the patients would be maintained. So basically, a lot of studies have shown that if treatment is taken at the right time, the structural damage is less in patients over the next few years. So this is something which is more for the doctors, but for the public, I would like to say that if your functional ability is maintained, then probably this indirectly also helps to maintain your employment, and all of these are interconnected. So your quality of life of the patient is also better, because if your employment is maintained, your independence is maintained, you have less fatigue, less pain, then you're able to do more work, and it like a normal person. And indirectly it also affects your mental health, so the mental health is also maintained if you lead a happy and healthy life. So the chances of anxiety, depression, all these which are more in chronic illness patients would be less. So I think a early diagnosis and treatment is a wholesome thing which would help in the disease and the well-being of the patient as a overall.
Right. So it is important for the quality of life and to prevent disability. Right. And Dr. Ajay, how has the diagnostic landscape of rheumatoid arthritis evolved over the last decade?
I think that's a very pertinent question. When we talk about rheumatoid arthritis, one of the most prevalent disease worldwide, and definitely in the last 1 decade, we have seen a significant change. I think the landmark was the launch of 2010 ACR Euler classification, in which certain criterias were defined, and the lab was given a pivotal role in terms of detection for rheumatoid factor and anti-CCP, and point system was given. And when we talk about rheumatoid arthritis, see, in maybe a decade, 2 decade down the line, we had only rheumatoid factor. And rheumatoid factor, though, was seen positive in patients with rheumatoid arthritis, but it had a limited specificity. That means it scored positive in other systemic autoimmune disease also. Then it came anti-CCP. Now, anti-CCP was considered as a very useful marker, still a very, very useful marker. It's a very specific and a sensitive marker. And so the landscape, when we talk about lab perspective, it came from rheumatoid factor to anti-CCP, and now we have a new novel biomarker, which is anti-MCV, or the mutated citrullinated vimentin. Now it holds a very high promise that it is considered to be an early biomarker for the detection of rheumatoid arthritis, and not only in terms of early detection, but it has a role to play in the treatment part, and then even in the prognostic part of the rheumatoid arthritis. Even when we talk about radiology, the introduction of musculoskeletal ultrasound, now with the help of this important tool, we are able to detect subclinical synovitis. So there has been in the last 2 decades recent advances in which we are able to catch hold of rheumatoid arthritis at a very early stage.
Oh, that's so good to know that even before the radiological, imaging shows it, you can catch hold of it. Especially, you're saying that for early diagnosis, treatment, and for prognostic, it plays a vital role. So, Dr. Ranjan, how do you see the limitation of current markers, like if we talk about RF and NTCCP in routine practice?
Yeah, so that's very important because as we have discussed, rheumatoid arthritis predominantly has two varieties. We say them seropositive and seronegative. And clinically, what we see is almost 20% patients are seronegative. So once we call them seronegative, that means our traditional markers, which is rheumatoid factor and anti-CCP, as Dr. Ajay has just told us, are not useful. So now what are we left with for these 20% patients? So we are left with clinical judgment, and once the patient has had a long drawn disease, we are only there to identify the damage on the x-rays. There's nothing in between. So the limitations with these two markers, the foremost is that a particular 1/5 of patients are not going to be identified by these two markers, so we need something else. Now let's come to their basic parameters, which are sensitivity and specificity. It has been told that anti-CCP, which has come later, is very specific, but then the problem with anti-CCP is that in these 20% patients, once we identify or define them as seronegative, we are talking about negativity for RF, that is rheumatoid factor, as well as anti-CCP. So for these 20%, even anti-CCP is not sufficient. We need a further marker for this. Now we talk about sensitivity. Sensitivity is barely 60%, 70%. So what anti-CCP adds to rheumatoid factor is the specificity, but given all those qualities, for those 20% it is still insufficient, so you need to have better markers. So the major limitations are rheumatoid factor non-specificity. It is not at all specific. You name the disease, rheumatic disease, where you can find it positive. Anti-CCP, even though it is specific, you don't have the sensitivity. So basically, one has a quality, both of them have one quality, but then there is a limitation behind all of them.
Right. So we may miss some cases.
Yes,
That's what you
exactly.
want to say.
20%, at least 20%.
20%. That's a huge number. So in your practice, what percentage again of rheumatoid arthritis patients do you typically see as seronegative, although you have told us, and how do you see that the in future we can improve detection of these patients?
Yeah, so the diagnostic marker, if you talk, the hallmark is still the clinical examination. You see the patient, you feel that it is rheumatoid, that's the first thing. That tells you whether I should test for, say, A or B or C. Now, having said that, there are times when you can't say that this patient is rheumatoid, may turn out to be rheumatoid when you are having, just the joint count is not sufficient to satisfy the criteria. So we are in dilemma. Now, how can we improve this? Improvement is definitely by finding better serological markers. So rheumatoid factor was the first one. We had anti-CCP. There were generations of different generations of anti-CCP, and now, as Dr. Ajay told, that in 2010 we had the criteria which told us that you need to test for both and then you decide. But then the future, I think, holds for better markers, like again Dr. Ajay had pointed out, Anti-MCV, that is coming up bigger way, in a big way now, and probably that will hold promise for future as well.
Right. So we have been talking about anti-MCV. So what is it like? Just tell us about the test and how does it differ from traditional markers such as RF and anti-CCP, Dr. Ajay?
MCV, or it stands for mutated citrullinated vimentin antibody. So we need to understand there is a difference between antibody and an autoantibody. So normally we have antibodies which fight against various bacteria and viruses, but it so happens that sometimes they mistakenly attack our immune system, and then they are called as autoantibodies. And these autoantibodies, they target our proteins. So when we talk about MCV, you can see the target protein is a modified vimentin, which undergoes mutation and citrullination. Citrullination is a process in which the amino acid arginine is converted into citrulline. This occurs inside the inflammatory cells like macrophages. Now, when these cells die naturally as a result of joint damage, it results in an immune response, which result in secretion of these autoantibodies, which is anti-MCV or the mutated citrullinated vimentin. Now, when we talk about the difference, although they are the members of ACPA, that is anti-citrullinated peptides, the anti-CCP and both anti-MCV, and previously we had rheumatoid factor. Now, we need to understand when we talk about rheumatoid arthritis and early diagnosis. So, what the literature says that 40% of the cases, some literature says that 40% of the cases are being catch hold by anti-CCP, but yes, 60% are being missed. So, and 60% is a huge amount. And also, there are quite a few cases which are seronegative. We need to understand those patients in which both the rheumatoid factor and anti-CCP are negative. We have to deal with such patients also. And in cases of seronegative rheumatoid arthritis, and when we see anti-MCV coming positive in such cases, it definitely helps in the diagnosis. When we have two biomarkers coming negative and anti-MCV coming positive, so we have a new biomarker which is showing us the way, yes, it can be positive. There was still controversy where the anti-CCP has a role in prognosis treatment part or not. Some literature says that as the titer of anti-CCP increases, it indicates corrosive disease or joint erosive disease, but still there is a controversy. But there are factual data on MCV that whenever the levels turn high, it indicates more of you patient going into, you can say, erosive serositis and all. So what I feel is that there are quite a few differences, and when we talk about these, maybe you cannot replace it, but what I feel is that anti-MCV along with anti-CCP can be tested, or even some literature says that you can go for a reflex testing. As Dr. Ranjan told, that if a patient is having a telltale signs of rheumatoid arthritis and for some reason anti-CCP is coming negative, in such cases, when you get anti-CCP negative, a reflex testing for anti-MCV can be advised.
So that's so good to know that they complement each other, right?
Yes, yes.
Seronegative may they have role, but also in the patients where anti-CCP is negative.
Yes.
Right. So again, you have partly answered my question that it is going to be a game changer. How do you see anti-MCV becoming a game changer in diagnostic algorithms for RA?
When we talk about systemic autoimmune disease like rheumatoid arthritis and the existing biomarkers which we have, the rheumatoid factor which has got a limited specificity, and we all know about anti-CCP and now anti-MCV, what should be expected from the new biomarker is catch hold of an early detection of rheumatoid arthritis to prevent joint damage. That is the first and foremost. And when we talk about testing algorithms from the lab perspective, at Dr. Lal Path Lab, we have launched this test a couple of weeks before as a single test. But I feel, yes, that it should be included in one of the panels of rheumatoid arthritis in specific. A separate panel with anti-CCP should be done because parallel testing of anti-CCP along with anti-MCV is mandatory now. Both of these markers complement each other, although slight edge in terms of specificity towards MCV and slight edge towards sensitivity in terms of anti-CCP. Yes, by testing both, we will be able to catch hold seronegative rheumatoid arthritis. And as I talked earlier, that we can also introduce, although Dr. Ranjan can throw more light on that, of the reflex test code, in which the anti-CCP can be negative, and if anti-CCP is negative, a reflex testing for anti-MCV.
So, Dr. Shalu, how do you currently manage seronegative RA cases and what are the biggest diagnostic challenges?
So, seronegative rheumatoid arthritis, that means the patients who have rheumatoid arthritis, but RF and anti-CCP both are negative. So, these are by definition negative patients. So, initially, although some studies say there's a difference, but we manage them initially with conventional disease modifying drugs, and then those who are refractory, we go on to biological drugs. So, the management initially is same, but it differs if the patient does not respond. So, that is where the importance lies, whether they are negative or positive. Coming to the diagnostic challenge, it is definitely one of the biggest challenge for the doctor and for the patient also. We, because when a patient comes to us, if the tests are negative, we need to purely rely on our clinical examination. But in our country, especially, patients come after visiting a lot of doctors, taking a lot of traditional medicines. So their symptoms are, or their signs are modified. So when a patient comes to us, we are not able to just by clinical examination say whether this patient has arthritis or not. So that again becomes a dilemma. And the second thing is that some patients who we think or we diagnose as rheumatoid arthritis, they may turn out to be other autoimmune disorders like spondyloarthropathy, psoriatic arthritis. Some patients have arthritis and they develop psoriasis later on. So that is psoriatic arthritis, which is a different entity. So fortunately, the conventional DMARDs are almost the same for all the arthritis initially. So we start with them. But then whether these patients, how they would turn up later on in few years, that really always remains a dilemma if we don't have a serological marker. So here I think if we have another marker with us, that would really help us in early diagnosis and treatment. And second thing is coming to the patient. The patient, when there is not a label, we are not able to label the patient that you have rheumatoid arthritis, they are always in a anxiety and their compliance is also poor, that we don't have the disease. So if the test is positive, it is for us and I think more for the patient, they are more satisfied. Yes, we have the disease, they accept it, and they take treatment more religiously. So I think
Right,
that's
so
what
that helps in
yeah,
compliance,
definitely.
right? So, Dr. Ranjan, if a new marker like anti-MCV can detect disease in such patients where it's seronegative, how valuable would that be in clinical decision making?
Yeah, so I think I would take off from where Dr. Shalu has just left. So how does it help? It helps because once we are in seronegative domain, it could be in either direction. It could be just rheumatoid. 2 years later, I may see development of say psoriasis in the same patient, and I would retrospectively diagnose that I was dealing with psoriatic arthritis. It may turn out to be say something else, maybe spondyloarthritis, another variety. So what happens is that I need to basically save these 2 years. I'm going to expect that something is going to happen in future, and can I predict it today? That is the whole question. Now I have already exhausted my two conventional markers, which is rheumatoid factor and anti-CCP, and they were of no use. So what I do, I test for another marker. I look for another marker which can give me some edge. And edge, I'm not talking about 1 or 2%. I'm talking about a handy 40%. So when I talk about seronegative rheumatoid arthritis, which makes almost 20% of all the cases, in which rheumatoid factor and anti-CCP is already negative. Anti-MCV, as per today's literature and studies, tells me that it can be positive in 40% of those 20%. So means my sensitivity of diagnosing seropositive rheumatoid arthritis shoots from 80 to 90. I'm able to catch hold of another 10% patients who were otherwise going to be labeled as seronegative. Now, is it only about the label? Is it about something else also? So, the next and most important thing, not for me and you, it is for the patient, is the treatment. How does it help me in treating? When I label the patient as seronegative, after the conventional drugs that just Dr. Shalu just spoke about, I come to biologics. Now, seronegative patients tend to do a bit better, but then there are conditions because these patients are not being caught by RF and anti-CCP. I'm actually falsely labeling them as seronegative, hoping for a good future outcomes, which is wrong. If I have another serological marker which is going to tell me that these are seropositive, I am already backing up for a poorer course and better drugs. So that is one thing. Number two, patients who are seropositive, they can be treated with a bit cheaper medication, a bit, I would say, economical, in a more economical way, because we can use rituximab in them, which is much more economical as compared to anti-TNFs. So if I spend a little money in the beginning testing these patients for MCV and get those 50% patients who were otherwise going to be labeled as seronegative but turn out to be seropositive on MCV, I can give them the benefit of using an economical medication, which is rituximab, which otherwise these patients would go into the basket for anti-TNFs, making the treatment costlier. So that's how it will probably be a game changer for at least those 8, 9, 10% patients who are going to be labeled as seronegative.
That is enlightening that it is going to be economical when we label them, yes, they have got the disease. Dr. Ajay, several studies suggest that anti-MCV has higher sensitivity and specificity in early RA and in seronegative patients. From your review of literature, how strong is the clinical evidence supporting its use?
So, again, when we have the review of literature, the sensitivity of detection of rheumatoid factor at an early stage for anti-CCP is around about 40%. Okay, now we are missing a big chunk of 60% of the patients. In addition to that 60% of the patient, we are also missing in terms of seronegative, which are negative for both rheumatoid factor and anti-CCP. Now, for those patients and the chunk of 60% of the patients which are not diagnosed at an early stage, and there is a clinical diagnostic dilemma which are not fitting in the criteria, right? And with the introduction of this new novel biomarker, MCV, and if we are able to substantially catch hold of this percentage of patients, I think it will be a big boon to both patients as well as clinicians. Because we, again, the bottom line when we talk about rheumatoid arthritis is early detection. We need to prevent joint damage at any cost. Definitely. And when we talk that, I think it's always that the clinical acumen holds the key. But yes, we all know autoimmune disease, they are very, very overlapping. You never know. So, with this introduction of anti-MCV, it looks a promising marker. We are hoping that it should fill in the gap which is there right now because of this rheumatoid factor and anti-CCP. We have studied these biomarkers over a decade. Now the time has come with the discovery of MCV and quite a few labs which have started this test, including our lab. Now will help to bridge that gap in terms of seronegativity and to catch hold of rheumatoid arthritis at early stage.
Right. And you both are clinicians. We have heard Dr. Ajay, like he's saying that this is the lab perspective, right? So, based on that, how do you see NT-MCV to be used in monitoring and prognosis? Let's start from Dr. Sharon.
Yeah, so I think, as Sir said, anti-MCV would bridge the gap of those 10 to 15% patients of seronegative rheumatoid arthritis. So we would be able to make a early diagnosis. Second thing is, because of the positive predictivity, it's uh, a correlation with of anti-MCV with the disease activity, morning stiffness. Studies have shown that they are positively correlated. So probably in the future, it would also help us in monitoring the disease. And definitely, if it is seropositive, the disease is more aggressive. So if we treat it more aggressively, we can prevent structural damage. So these are things. And another thing is that early diagnosis means early treatment. So the referral rate from the general practitioners would also increase, because if they are aware, yes, this is rheumatoid arthritis, they can refer the patient directly. It's often seen that seronegative patients, they keep roaming about because they don't have a label. Whether they have the joint swelling, they are not treated, with full confidence because of the lack of the reports. So I think that would be a game changer, and it would help us in early treatment and diagnosis.
Right. So, it'll improve the reference system as well. Dr. Ranjan.
So I completely agree with Dr. Shalu that it is going to be useful not just in diagnosing patients early, but also treating them economically and then giving them a prognostic picture for their future. And I know that patient is not just seronegative, it is positive for MCV. I can always predict a worse outcome, an aggressive course, and I would be ready with better drugs for him or her in future. So I think it is going to help us in all the three domains, which is diagnosis, treatment, and prognosis.
Right. So, clinical decision making as well. And you have been talking about, ma'am, the referral part. So, how important is awareness among journal practitioner and patients for early referral and testing with such a new marker?
Well, I would like to say it is the pillar. Like, the awareness among the patients and the general practitioners is something very important, because in India, or probably elsewhere also, patients do not directly reach the rheumatologist if they have joint pain. Still, they go to their own physician whom they trust. And so that is the person who would, send the person in the right direction. So the first thing is that, yes, the general practitioner should be aware of the disease and the newer testing modality, so that the patient can be diagnosed early. The second thing is the awareness in the patient. I think that is the most important thing, because if the patient is able to relate his symptoms and go to the right person early, I think that solves all the problems, because once you reach the specialist, the right treatment can be started. I think the first step is awareness, second is action. So once you're aware of the disease, take action, and I think you can lead a very normal and a healthy life by that.
Right. And I think with discussion, we must be having some very good key takeaways. So, what would be your advice to pathologists and lab professional and clinician about integrating NT-MCV into routine practice? And this question is open for all. So, let's start with Dr. Ajay.
We, as a lab person, I think we are into testing for rheumatoid factor and anti-CCP since decades. And now we are testing for anti-MCV, and to assure the clinicians and all the rheumatologists that this test is performed on a fully automated analyzer. There is no manual intervention. Just we have to keep a sample in the machine, and it will test and it will give you the readings. And before that, the machine is duly calibrated. All the QC checks of the positive control and the negative controls are done. It is the responsibility of the lab when the test is coming positive. I think all the other tests, sometimes we don't have the clinical details available with us, but we can definitely correlate with other lab results. So CBC is there, a ESR is there, or maybe an anti-CCP is available, or rheumatoid factor is available, because it's a new test. So it should be awareness for the lab that when we are releasing the reports, especially the positive cases, we need to have some sort of a correlation, either a clinical correlation or the correlation with other lab results. And in context to your previous question, I was going through an publication in an index journal. In Indian scenario, what they have told, not for rheumatoid arthritis, but for whole autoimmune disease in general, that from the onset of symptom of autoimmune disease in a patient to the final diagnosis in India, it takes about 2.5 to 3.5 years. So I think what Dr. Shalu was saying, awareness, there is a huge need, huge need for awareness, not only in terms of to public or patient awareness, but in terms of clinicians, not for the rheumatologists, but yes, for the general practitioners.
Yeah, so I think I would also like to say that anti-MCV is a test which should not be used solely as a alone test. It should be used as an add-on to the other test with clinical correlation. I think that is very important. Otherwise, some tests are, overused, or I don't know if I should use the term, they are abused in a, and that becomes a problem. Yeah, so I think the test should be used with clinical correlation. It is definitely a test which would add on to the, earlier tests, but using it solely would, I would not say right now it would be the time to use it alone. So I think
So it
that's what.
is definitely complementing other tests and
Yes, it
fitting
would
in the
complement the serological
diagnostic,
accuracy
right,
basically.
diagnostic
Yes.
algorithm, right.
Yeah, so again, the most of the things have been said by Dr. Ajay and Dr. Shalu, but I would just make a point based on what evidence we have today that anti-MCV does not have much edge in sensitivity and specificity as compared to anti-CCP. So what we should do is give the conventional test first, but where MCV scores, anti-MCV scores in two particular types of patients. Number one, who we do not have a diagnosis, they are just through their early disease. It may be within 3 months, 6 months. Those are the patients where anti-MCV scores over anti-MCP, anti-CCP. And the other part where it scores is that patients who are seronegative. Patients have had a long drawn course, still they are being labeled as anti seronegative. In those patients, it scores, and there, in both these situations, anti MCV must be used. I would not even say should be used; it must be used.
So, on that note, I think we have key takeaways that for early diagnosis and for complementing other tests, this is definitely going to be a game changer. So, with that note, I thank you, all of you, for joining us today in this important discussion.
Thank you.
Thank you.
Thank you so much.